Chapter 24, Hematologic and Renal Emergencies. So this chapter will go relatively quickly. Our treatment for these patients doesn't change very much. The focus here is going to be on assessment and identification of the underlying conditions and transport to the appropriate medical facilities. The hematologic system deals with our blood. And if you think, think forward to when you start talking about trauma, we'll talk about things like a hemothorax. So hemo having the prefix for blood addresses all the things related to the blood itself. Now this is different from the circulatory system. The circulatory system has to deal with the blood vessels, dilation, constriction, everything else. Hematologic here is just strictly the blood. And the blood does represent its own organ system. And it's got a handful of functions as it shows here. Our blood not only helps to transfer heat throughout the body, it helps to deliver nutrients, get rid of waste, it helps to maintain adequate pressures, it helps to fight disease, it helps to cure us when we are injured or ill. A lot of things going on there. So the blood, needless to say, is extremely important. As a quick review from your anatomy and physiology chapters, the blood is consisted of 4 primary components: the red blood cells, the white blood cells, platelets, and then all 3 of those components being suspended in the plasma. Also keep in mind the medical terms for each of those. A red blood cell is a erythrocyte, a white blood cell a leukocyte, and a platelet is a thrombocyte. We're going to want to keep an eye on those terms for the upcoming exams. So I'm going to start with a brief video here that kind of illustrates how blood clotting occurs. And this is stuff that we should understand going all the way back to the cardiac chapters, talking about the administration of nitroglycerin for a blood clot, and also to think about moving forward into our trauma chapters as our body tries to clot bleeding wounds.
Even under physiological conditions, a small tear can appear in the wall of a blood vessel. In order to prevent blood loss, platelets and coagulation factors, such as the pivotal factor 10, acting in a coordinated manner, close this wound. The platelets are responsible for a first sealing of the tear. Then, a number of coagulation factors are activated, leading to the formation of fibrin strands which stabilize the growing clot. These processes can also be triggered inappropriately and play a major role in the pathology of ACS, VTE, and AF. Thromboembolic disorders can affect both types of blood vessels. Arterial or white clots are primarily triggered by the rupture of an atherosclerotic plaque. Arterial clots are platelet-rich. Venous or red clots, on the other hand, mainly consist of red blood cells and fibrin. Vascular injury, hypercoagulability of the blood, and venous stasis play a crucial role in their development. It is important to note that the formation of both types of clots, arterial and venous, always involves platelets as well as coagulation factors.
So that video really does a nice job of illustrating how the clots form. But beyond understanding that just simply on clot formation, again, think back to, why is it that we administer nitroglycerin? Why is it that we administer aspirin for patients with chest pain? And thinking about those atherosclerotic clots, if the nitroglycerin helps to dilate the blood vessel, it will allow blood flow around the area of the clot. And if the aspirin helps to prevent that coagulation factor from being effective, but that's what it actually does, is it adjusts the coagulation factors so that those platelets continue to kind of bounce off the clot rather than continue to stick to them. So there's a lot that goes on with clot development, nothing that we need to get real in depth with, but just understand the basic components that video showed you. Now, some people aren't able to clot appropriately. Some people clot too often, or they don't clot enough. And in those situations, they're typically treated with advanced medications. And those medications are something that you should hopefully be provided throughout your sample history. And a lot of them, you may not know what they are or what their primary purposes are. And that's why you've got the Google device. Bring out your phone, Google the medication name, and figure out what exactly it's for. So certain conditions that necessitate that, people who are on blood thinners are typically associated with things like, let's say, atrial fibrillation. And with AFib, because the heart or the atria specifically quiver instead of pumping blood efficiently, there's a high risk for clot development there. So they put them on blood thinners that prevents the patient from forming clots appropriately. And what that does is that helps to protect against heart attack, pulmonary embolism, or even stroke. On the downside, though, those patients are, in fact, unable to clot. So when it comes to trauma, specifically head injuries and stuff like that, it's very difficult for the body to form those clots internally, like you saw in the video. And as a result, we have a lot of a substantial potential for internal hemorrhage, whether it be through intracerebral hemorrhage or something within the abdomen, chest, or elsewhere. You also have the potential for anemia. And anemia is just where you don't have enough red blood cells. So we could have a sufficient quantity of plasma to maintain adequate pressures in the body. But if we don't have enough red blood cells, then we have a difficult time transporting the oxygen and also getting rid of carbon dioxide and other waste products. And that anemia can be acute or it can be chronic. Chronic things where females have excessive menstrual periods, on a routine basis, or even the irregularities there. People that have a history of GI bleeds, those things can all cause that chronic red blood cell deficiency or that chronic anemia. The acute anemia, though, would be something more abrupt, whether it be a particular hemorrhage, that would probably be one of the primary causes. Think back to childbirth, for instance. A female who hemorrhages substantially following childbirth could be anemic for a period of time. So there's lots of causes there. Nothing that we can do pre-hospital to actually treat it, but identifying the potential for it and understanding the importance of rapid transport and also getting them to the appropriate medical facility is our primary objective. Something called sickle cell anemia actually causes a misformation of the red blood cells, and they actually resemble the shape of a sickle, hence the name. And when that happens, we have a difficult time binding blood. The hemoglobin itself isn't working effectively. We can't bind the oxygen to the hemoglobin, and as a result, we have a lot of respiratory or hypoxia issues. Now, there are certain demographics that are most prevalent with sickle cell anemia. Again, for us, though, it really shouldn't be a concern. We're going to identify signs and symptoms, identify risk factors, and transport as appropriate, regardless of the patient's ethnic backgrounds. Along with the sickle cell anemia and the potential for hypoxic issues, we also have the likelihood of pain in the joints. And what it is those red blood cells kind of get bound up. They don't necessarily form clots, but they do stick to each other, and they have a hard time getting through smaller spaces, especially in the capillaries. And what ends up happening is people get a lot of pain at those areas. And we seem to see those at the joints, the knees, the elbows, the wrists, those types of areas most frequently. So you see a handful of complications that result from the sickle cell anemia. So a patient who has sickle cell anemia, nothing we can do particularly to treat it in the field. You'll see on the screen a list of complications that can result from sickle cell anemia. Anything here that we can potentially treat the signs or symptoms of, that's fine. Beyond that, though, there's really not much we can do. So I'm going to go ahead and play this video for you. It's a short video that illustrates how sickle cell anemia actually works and the potential causes from it.
Sickle cell anemia is a genetically transmitted disorder marked by a severe reduction in circulating red blood cells. Red blood cells are produced in the red marrow of bones such as the vertebrae, ribs, and body of the sternum. Red blood cells are filled with hemoglobin that enables them to carry oxygen from the lungs to all of the body tissues. In sickle cell anemia, red blood cells contain an abnormal form of hemoglobin. As the red blood cell deoxygenates, the hemoglobin forms crosslinks with other hemoglobin molecules, and long crystals develop. Crystals continue to form as oxygen is released, and the red cells assume a sickle shape. Sickled red blood cells are inflexible and rigid, and cause mechanical obstruction of small arterioles and capillaries, leading to pain
and ischemia. Sickled cells are also more fragile than normal, leading to hemolysis. Tissue death secondary to ischemia progresses to organ failure with repeated occlusive episodes. Sickle cell anemia cannot be cured. Treatment is aimed at preventing sickle cell crisis, controlling the anemia, and relieving pain. Blood transfusions and fluid replacement expand blood volume and oxygen exchange needed for reperfusion of occluded vessels.
So as you can see, sickle cell anemia is a pretty nasty disease. Unfortunately, there are no cures for it. Patients who are diagnosed with this will tell you right away that they're having a sickle cell crisis. And again, just treat the patient's primary complaints, providing any comfort care that's available at the time. Moving into the renal system then. So we'll talk a lot about the kidneys, the urethras, the ureters itself, everything having to do with filtering a lot of the toxins out of our body and trying to excrete that through our urine. So the renal system is responsible for filtering the blood, and it removes the waste product. Along with that, it helps us to maintain fluid balance. So the renal system plays a big part in hydration status. If we have an excess amount of toxins in our body that the blood or that the kidneys need to filter out, then what ends up happening is we end up excreting a lot of additional fluid. And that's the primary means in which the body can actually excrete that stuff, is we take water within our body, it gets filtered into the kidneys, we pull a lot of the nasty garbage out of the blood, and then we excrete that through our urine. If we are constantly filled with toxins, we tend to urinate more often, and that's where we get dehydrated. And that applies to a multitude of things. It could apply to a hyperglycemic patient, but it could also apply to somebody who's been consuming a lot of alcohol or even poor dietary habit. So with the renal system itself, there's a handful of things that could occur, anywhere from kidney stones to urinary tract infections and everywhere in between. And a lot of these things, while they can typically be acute and easily treated, also have the potential to become very serious, if not life-threatening, if they go untreated. Urinary tract infections are something that we run across all the time. Most common in women, more so than men, and we see these a lot at the elderly stages. So that doesn't mean that we can't have them in young children or adults or any other age bracket. We can certainly see it in males. We just see it most common in females that are elderly. And with those, what ends up happening is it is just an internal infection. If it's not appropriately treated, then what we run into is the potential for them to become septic. That infection runs backwards, up the urethra, through the ureters, it can get up into the kidneys, and if the kidneys stop working effectively, those toxins tend to back up into the system, and we can have acidotic issues. We can also have widespread systemic infection. Kidney stones. If you've never seen somebody with a kidney stone, or even if you've ever had it before, these things are just incredibly nasty. The kidney stones are small rocks, if you will, of calcium that form in the kidneys. Now, sometimes they're large enough that they can't be passed at all through the ureters. Sometimes they're small enough that they can be passed on their own. The problem is, as these small stones pass down through the ureters and eventually in through the urethra, they are extremely, extremely painful. They're actually causing trauma to the inside of those tubes as it travels through there. Probably one of the more painful things that a patient can possibly experience. Now, there are circumstances where those stones are so large that they can't pass into the ureter at all. And when that's the case, we seem to have the pain that's localized more so up in the flanks, and we can start to feel some radiating pain down toward the groin. The only thing we can do for these patients is sympathize for them, put them in a position of most comfort, and transport them. What they ultimately need is going to be some high-dose pain medications, and they're going to also have to see what they can do to get rid of those stones themselves. Indications of a kidney stone is typically going to be flank pain, one side or the other, around the area of the kidney, and that pain will typically radiate down toward the groin. They may complain of blood in the urine. They could also complain of a burning sensation when they urinate, and these are probably the biggest things. For some people, the pain radiates over toward the back. So any of these things that they begin complaining of, we should identify the potential for the kidney stone and the need for a transport to get them some level of comfort care. Now, piggybacking off the kidney stones, there are times that a urinary catheter needs to be put in place. And that may be to benefit a patient with a kidney stone, but it could also be for a multitude of other reasons. Urinary tract infections could be a need, bladder infections. Sometimes patients, or more often than not, patients who are intubated or sedated, they'll end up getting a urinary catheter. And the benefit of these is it allows the urine to escape passively without the patient actually having to get up and use the restroom. From our perspective, there's a couple things that we should consider. As we arrive on scene of a patient who has a urinary catheter, we have to be extremely careful to pick that bag up and make sure that we're moving that bag with the patient and prevent the hose from getting caught or snagged on anything. You can only begin to imagine how painful and uncomfortable that must be on the patient if it does end up getting snagged or pulled on. One benefit to us, though, is we are able to examine the patient's urine and identify the presence of any type of blood or any discoloration that could suggest that there's an underlying infection. Some patients go into what's called renal failure, and that's where the kidneys begin to shut down and stop doing their job. The hazards of renal failure is that we can't effectively excrete all the toxins from the body now. So we end up retaining a lot of these toxins. We also end up retaining a lot of fluid. Now the upside is we have two kidneys, right? So as long as one kidney is working, we can typically go without the other. One will kind of pick up the slack for the other one. However, with our renal failure patients, we tend to see this be chronic on bilaterally on both kidneys, and it's a tough thing for them to deal with. A handful of things that can contribute to renal failure, including the diabetes and chronic hypertension, but we know that the inability to properly balance the fluid and excrete all the toxins can really lead to some troubles for our patients. Patients who are truly in renal failure are considered to be end-stage renal disease, or ESRD. And what ends up happening with these patients is they need to go on dialysis. We have to use external means to try to filter their blood for them to do the job of the kidneys. And there's two separate types of dialysis. You can do hemodialysis or peritoneal dialysis. Hemodialysis actually filters the blood through the body into a machine, and then the machine filters it out and puts the blood back into the body. And patients will have to do hemodialysis depending on the severity. It could be every single day, it may be a couple times a week, or maybe just once a week. But this really affects the lifestyle of our patients. These patients who are on dialysis on a regular basis, they can't go on vacations necessarily. They can't enjoy some of the basic luxuries, especially the patients who have to go to dialysis almost every single day. It really is a tough lifestyle change. You'll see here with the hemodialysis that there's what's called a fistula with ports, and that fistula is permanently implanted into the patient's arm, and it allows for the blood to go ahead, pull the blood out, or I'm sorry, for the machine to pull the blood out. It filters everything through, and then it goes right back in. We need to be careful to identify the presence of those fistulas. We want to avoid doing a blood pressure on that arm if at all possible. It can end up occluding the fistula and causing some pain and discomfort. So that's pretty much what we're talking about here. You can also have a centralized port in place, and these ports are put into central arteries, or I'm sorry, central veins that allow for the same thing to occur rather than in the arm itself. You'll see one here, right? This is a fistula that's been permanently implanted, and what it is it allows the dialysis company to access one side to pull blood, access the other side to replace the blood then. We also have something called peritoneal dialysis. That peritoneal dialysis is something that's being done at home. This is actually an option that's been available in Europe for quite some time, and it's just recently begun to gain popularity in the United States. And what it does is it allows patients to inject a fluid directly into pretty much it's a cavity within the abdomen there. And what ends up happening is over time, it is that cavity, that fluid, draws the toxins into it, and then it's able to be excreted through that same process then. So again, that's something that's done at home quite frequently. It's much less invasive and just as effective. With the peritoneal dialysis then, you'll see that there's a couple different types here. Really not anything that's relevant to us. We should just understand the basic concepts of dialysis and the two different forms. And you'll see here, so this is the ability to inject the fluids and then again to pull the fluids back out with all the waste products in them. With dialysis patients, from time to time, we'll run into complications where they have bleeding around the site of the port, and those typically can just be controlled with direct pressure. From extreme rare circumstances, they can actually begin to hemorrhage, and if that's the case, there's very little that can be done in the field. That's just a matter of identifying the signs and symptoms of a hemorrhage and rapid transport. Now we have to consider the potential consequences of that. So the purpose of dialysis is to remove waste products and to balance out water. What happens when we don't do that? Well, those waste products are retained in the body. We can become sick, we can become acidotic, and it throws off our pH balance. And in addition to that, we're unable to balance out our fluids. So we tend to retain a lot of fluids. That fluid retention can come in the form of edema. It could fill up the lungs. It can put undue stress on the heart. There's just a lot of stuff that can go on as a result of that. So these patients may present with any number of complications as a result of that. We're going to have to identify those complications pre-hospital, treat signs and symptoms as we can, and then again get them to the appropriate facility. And this just reassesses or reiterates what I just said there as far as identifying signs and symptoms and treating them. This slide just lists some of the specific complications that we can see from the different dialysis procedures or lack thereof, and just some brief explanation of how to identify those. So, in short, anybody with the end-stage renal disease that has missed dialysis or has any complications related to dialysis, we should be monitoring their ABCs, identifying potential signs and symptoms that can be treated, transporting them to the appropriate facility then. Kidney transplant patients, a lot of patients that have end-stage renal disease go on a transplant list, and that transplant list allows them to potentially get a healthy kidney that will promote this process naturally, and they can get off dialysis. These patients, as with all transplant patients, are at risk of rejecting their kidneys, and they can still have similar complications as with anything else. So again, not a lot of information there, short and sweet, to the point. The big takeaways here is we can't do much in the way of hematologic or renal emergencies. We can identify the potential likelihood that something exists, but we're not going to be able to really establish a confident differential diagnosis in the field. Moreover, we should just suspect some of these things, make sure that we're transporting to appropriate facilities, and then treating any signs and symptoms as they may present. So that's all for this chapter. I hope you enjoyed it.